the topic this week is interesting. I have been spending in many different capacities a lot of time working with and thinking about the national network provider directories, types of participants, who's participating, who's not, should they be participating or not, for various exchange purposes, all part of the work we do both internally here at Zen as well as in my role as co-chair of the Carequality Advisory Council this year, which I'm lucky enough to co-chair with Liz Lewis from Be Well. And so I just felt like this was an opportunity to dive into that topic specifically. So that's what we're doing today. For those of you who are new, and I do recognize a lot of you, but for anyone who I've not met before, just so that you know who I am and we are, I am the president and co-founder of Zen Healthcare IT, and Zen is an interoperability platform company. We combine our platform with our really smart interoperability subject matter experts, and we support both what I would consider traditional healthcare interfaces as well as optimized API-based connectivity to all the national data exchange networks. And it's really, that is going to be kind of the focus for our conversation today, are those national data exchange networks. As many of you know who have joined us before, we like to have fun with kind of having a sponsor. The sponsor for this session is Zen Command Center. It is something brand new that we've rolled out for our clients. It's a nice modern web UI, sits on top of everything that we do, whether people are doing traditional healthcare interfaces with us or they're involved in national exchange. Command Center has kind of something for everyone. But today our focus is really on the national network participants, and our Command Center does include a view of the national network participants. And so it'll drive a little bit of our conversation today. We personally found that our customers had a big need to be able to have a human usable, not just a spreadsheet view of the networks that they were participating in. If you don't happen to be a Zen Stargate client, but you are interested in having, and you're a network participant, but you're interested in having a better view, feel free to put interested in the chat window. This is something that we're going to start making available for any validated network participant for a small fee. So we certainly are interested in getting a survey of folks who might be interested in something like that. So those are for people who aren't already a Zen customer. So why did we feel the need to do something? And I'm going to show you in a minute the directories that are publicly available, and the kind of information that you can get there, because that's important for you to know what, and they have evolved quite a bit, I would say, over the last couple of years. I even saw some things new that were not there the last time I looked. So there is some good information there. So I want to make sure you're aware of what's available publicly for each network. But our customers felt like they needed more detail. There's a lot more information available in the directories themselves that aren't exposed publicly. They need to be able to have a multiple network view from one search, because a lot of our clients are participating in multiple networks. They needed to be able to see details like active versus inactive status. They needed to look at OIDs, which are kind of the unique identifier for the network participants, access technical contacts when they're trying to troubleshoot connectivity. Maybe they're trying to do a delegation of authority form and need some of that information, or simply need to know what's changed, who's new to the directory that maybe I could be exchanging data with that I'm not aware of. So with that, I'd like to pause for a second. I'd really love to hear from the folks on the call, from a handful of you that are network participants. How are you using the provider directories available to you today? And just go for it. It's still a small group. And otherwise, you get called on. So Scott, I'm going to pick on you, like as normal. I know that you have, in your role with the Reliance eHealth Collaborative, a regional HIE based out of Oregon, and you guys are participating in eHealth Exchange. I know that you have talked a little bit about the directory and how you use it. Could you maybe comment on that?
Sure. Yeah, I think the the notable case that comes to mind is we've used it to troubleshoot or respond to some questions about network participation from our customers. And I'll have to pull up the exact instance of it. I may need to call on my interface analyst, Mike, to help jog my memory. But there were some pretty intricate questions that came up from a network participant that had operations in Oregon, but was is actually headquartered in New York State. And really having a single pane of glass to look at that network participation helped us disentangle that and respond appropriately to the customer, where we might have taken maybe 5 times as long, or maybe would not have been able to have as much information to reply at all.
Yeah, I think you're maybe talking about the hierarchical structure and relate the complicated relationships between, the top level kind of parent organization, and then the various facilities and regions, and that detail isn't always clear when you're looking at the publicly available directories. Just by necessity, hard to display that kind of detailed information. So yeah, that's a very good use case, and certainly one that we see. Let's see, who else can I pick on? Emily.
I'll give an update.
Oh, Mark, go for
What?
it.
Yeah, High Solutions. Hey, Scott. Nice seeing you again.
Great to see you
Uh,
again, Mark.
in a nutshell, we haven't landed on a single provider directory at this point. We haven't built one, we're not leveraging one, we're not connecting to one. Our default is and continues to be the good old NPAS NPI registry in identifying providers. And the hope is, there's been a mandate set forth that says for providers, you must go and update the directory, get your ANG and make it happen. And obviously that's not going to be successful by just asking somebody to do it. And then the next thing that's coming down the pike is a federal mandate to basically create a universal provider directory with a federal mandate sometime in the future. So we're hanging in for that to happen before building anything else. That's sort of where we are.
Yeah, understandable. And I think everyone is in a slightly different place. There are some folks that are already participating in like Carequality or TEFCA or eHealth Exchange, and they're looking at a network from that perspective, just that particular network's perspective. Some are multi-network participants. But I think it's a good call out about the NPBS directory. We are experimenting with what's been made available so far, kind of the new efforts in that arena.
Yep.
Because again, until we get a universal directory that literally reflects every single possible way that you connect to someone and make it really usable in the real world, we feel like we can keep fulfilling that as from an interoperability perspective, and our role as an interoperability platform provider, or in our role as just an entity that can provide assistance for people that are participating in specific networks and therefore have the rights to pretty detailed information. But it's a good call out. We are looking to see how we might be able to incorporate that along with our other directories, so that you could slice and dice providers from multiple pathways, from a connectivity perspective. So that's a really good call out. All right, we'll move on, and we're going to stop and pause as much as I possibly can in this presentation. So one of the things I wanted to do is just, for those of you who haven't seen, if you're participating in national networks, and I'll talk a minute just quickly and kind of categorize them. So I personally think of Carequality and TEFCA as trusted exchange frameworks. Carequality being what I call kind of version 1, the first trusted exchange framework that had this concept of pulling together multiple networks. And so examples of other networks that participate in Carequality are eHealth Exchange, Commonwealth, the Epic network. And so in Carequality world, we call those implementers. eHealth Exchange and Commonwealth are both examples of very large networks on their own. They're nonprofits. And they're also implementers. They are also both QHINs. And because Zen is participates in all of these as a certified solution provider for them, we tend to be, we kind of focus on these as common pathways to get to either Carequality or TEFCA in addition to those networks on their own. So each one of those do publish their own network. I think one of the newest ones and ones that certainly is super important to be aware of is TEFCA now does have their own map where you can do an organization lookup, and it does include an address lookup. So that is very useful if you're looking at folks specifically in the TEFCA network. For Carequality, same thing. You've got name, city, state, and zip search. You'll notice in Carequality, you've got an export option. So once you do your filtered list, you can click the export to kind of take that list with you, if you will. Commonwealth has a very nice published network. I will say this, the Carequality network is Carequality participants. TEFCA are TEFCA participants. Commonwealth is Commonwealth participants. But this is, if you participate, if you want to know who's in Commonwealth, this is a great site. Again, address search is supported here. And eHealth Exchange also has for their network, they do both a list view and a map view. So those are available, but they're missing some things that, as I mentioned, some of our customers in particular needed access to, both from a multiple network perspective as well as missing details. So that just gives you a little bit of background information. I want to talk for a second about one of the things that I'm going to be talking about on this call, because I've had all this provider directory information on my mind. I've been thinking about it in terms of, well, what can we learn about the information in a really big provider directory like Carequality? Carequality is the oldest trust framework, in the sense of this idea of pulling together multiple networks. I think eHealth Exchange folks might argue with me there. Arguably, it was the very first to be a national network, has a lot of regional health information exchanges in it. But it does participate in Carequality. So you get kind of this additive effect. If I drop into the networks itself, if I look at eHealth Exchange, this looks so large because in this particular view, we're showing eHealth Exchange plus Carequality entries. So this is kind of a combo view. This view of Commonwealth is just like Commonwealth by itself. But if you opt into Carequality as a Commonwealth member, which our customers do, you get this would be Commonwealth plus Carequality, or Commonwealth plus Carequality plus TEFCA, because we have a lot of multiple network opt-ins. And so if you're an eHealth Exchange member, you might, in this case, we show that someone's opting into Carequality, but you also might be opting into Carequality and TEFCA-based exchange. So obviously it becomes a very complex ecosystem. But I decided when I wanted to really dive in and see what the data was going to tell me, I decided I wanted to start with something that was kind of a known entity. And so I thought, well, let's focus on Carequality. And one of the other drivers for me was we're having a lot of discussion in our governance, Commonwealth as well as Carequality, around trust, who should be participating in national network data exchange under the national network umbrellas. We certainly, I think most of you know that TEFCA has a very specific definition around who can participate in exchange when we mandate response, which TEFCA calls that required treatment. And the reason that's important is that network participants, if you are using the exchange purpose called required treatment, you must respond. And in Carequality, there's only one version of treatment. It's the same reciprocity requirement. You must respond. So anytime someone has to respond to an inbound query from another entity, there's obviously a lot of concerns about who those entities are. And given some of the trust challenges that we've had over the last year and a half that you've seen emerge from letters being sent to the TEFCA RCE or lawsuits maybe that have happened, we have a responsibility in, let's just say, Carequality, because I'm part of that governance group, to look at these problems that we're running into where trust is getting eroded and say, has TEFCA actually taken a better path? And should we align with TEFCA in order to enhance trust for those providers to make sure that who they're sharing data with are HIPAA entities. Very specifically, TEFCA calls out HIPAA covered entities. And what some of you may not know is because Carequality predated TEFCA and it had didn't have a specific language around the definition of who could participate under HIPAA. What you will see as I go through the analysis here, that there are some providers in Carequality that are not technically covered entities in the sense that they don't do HIPAA covered transactions that are specifically called out in the law. Carequality says that you also can share data under the framework if you're covered specifically under the information blocking rules, which was kind of a recent update to the Carequality data sharing agreement. So this Carequality's aperture is a little bigger. Therefore, it's been around longer than TEFCA. So long story short, that's why I decided to do my analysis using the TEFCA network as a starting place. And I will pause there. Any comments or questions? All right, I'll dive into my caveats of my experiment. As I said, I focused on Carequality. When I used an LLM, I kept the data very minimal. I only used the org name and the address. I wanted to make sure that I was only using data that was available from each one of the publicly available sites. So none of the other details that we have access to, but that aren't publicly available, were included in the analysis. And primarily I was focused on, can I infer the organization type or specialty based on the directory name? And as I was working with the LLM, we did a ton of iterations. I made a lot of decisions. There was no guessing by the LLM. And after a tremendous amount of time and effort, I actually was able to get about 75% of the overall Carequality population categorized. Granted, it's an LLM, they make mistakes. So it's not perfect, but I think it probably gives us a good sense overall of how the participation breaks down by org type and specialty. And if you decide to do this, which of course you could, because as I showed you, you can export things from the publicly available websites. I'll just warn you, be prepared to do a lot of iteration and you might run out of credits multiple times. So. Any questions on my methods? All right. I saw Mike shake his head. All right, so let's look at the outcome. Some of this is information that is, if you look on Carequality's website, looks very similar. And this was as of June, I think, 22nd data. At that time, we had 183 overall participants, about 150 of those active and 32,000 inactive. We are going to come back to active and inactive, and this is where, Julie, I might call on you, so be prepared. This is how it looks from a geographic breakdown. I think, again, this is pretty expected, and Carequality has a very similar view sitting, on their website where you can see the kind of density, and it would be, of course, larger population states have more density, which you kind of expect. But one of the things that's kind of interesting is that in this analysis, we can actually see how it breaks down by active and inactive. So that's kind of interesting. This gives literally every state and its number of participants. And so I want to talk real quick about active and inactive. So for some of you, you may not be, and even I am guessing at what that might mean. So active is obvious. You should be able to exchange data with that participant. They're turned on, if you will. Inactive should mean that they're turned off for some reason, but why? So there's a number of reasons why somebody is turned off or they're not turned on yet, because it could be the fact that they're a new entry that just hasn't been fully turned into production yet. So why would someone turn off network exchange? Well, they could have had a change in technology. They might be changing EMRs. They might have changed gateway providers if they're using a third party like Zen to access the network. And so they may temporarily be offline to only come back later under a different EMR or implementer. It could be that the organization itself was closed, acquired, or rebranded, or they just flat could have decided no longer to participate. Maybe it cost too much, or maybe they started to have trust concerns. Or it might be a new entry that isn't yet fully been put into production. So they could be in the middle of going live. And so I know in our case, when we're adding new entries to the directory, when we're in the process of moving them into production, we may have to wait on our customer. So they may get added to production, marked as inactive. We're waiting on our customer to finish up something to be fully ready, and then we would activate them. So we could be catching some entries that are just in that state. It could maybe be a delegate entry. Some of you may be familiar with the delegate of authority process. That's where you have an entity that's already on the network with their core EMR, but they've got a business need to have another piece of technology that they're using, have access to the same information. So they're using a second piece of technology. And in that case, they fall under this use case called delegation of authority. And there's a whole business process around that that can take, 2 to 3 to 4 weeks, unfortunately. But I think my guess is that some of those inactive entries are probably going through that process. And Julie, this is where I would love to circle back with you. Do you think I missed a use case of where an entry might be marked as inactive?
I don't think so. Sometimes people just choose to no longer participate in the network, or people have been marked inactive because their businesses have gone out of business as well. But other than that, I think that you're hitting the nail on the head for why people are marked as inactive.
It is interesting, and one of the things that we did add based on a request for our directory is the ability to see changes, so you can actually get to the information of who's getting removed versus who is getting added, and that is certainly very helpful information. It can help you discern, that big group that is inactive that could mean a lot of different things. It's useful to be able to kind of, tell the difference there. If we go back to our view, what's interesting here is looking at the state geographic data by percentage of inactive. So we can see Arizona appears, based on this analysis, to have the highest inactivity rate, and that's why I wanted to talk about what inactivity means. It could mean that a very large group that maybe had a big umbrella of a lot of individual facilities got turned off, or it could be the opposite of that. And we may be seeing a lot of new Arizona sites, coming into the network. Some of those things, are fun questions to ask. But I didn't have time to go into, further. And again, because I limited the information that I was using with the LLM for, I really didn't have any ability other than to know that these particular states are showing up, Arizona and Colorado specifically, with relatively high percents of inactives. My LLM gave me a full state-by-state background, but where it really got fun is in the provider specialty analysis. So I'm going to zoom in so you guys can see. So I guess not unexpectedly, primary care, federally qualified health centers, hospital health systems, individual provider groups, kind of that core, if you look at the top 5 is mostly, primary care focused or hospital health system focused, represents a huge chunk of the participants. And then we drop down, and what I think was kind of amazing is that just by looking at the name of the entry, we were able to tell with pretty good confidence. Again, I wouldn't swear that these are 100% accurate, but it gives us a good sense, I think, of the relative distribution of different specialties in, as participants. And many of these are, just flat specialties. But we've also got people like laboratory and pathology. And as we get in this smaller group, like social services and community support, Indian health services. So let me pause there for a minute. Anybody have any comments or want to see something or ask a question of the specialty data that I just showed you? Because I could zoom in.
Is there a reason that the dental is so low and so small? That surprises me.
Well, what surprises me is that dental showed up at all.
Oh.
It probably just depends on your perspective. I was thrilled to see some dental showing up. But
I mean, you have a dentist on every corner these days.
Yes, but I'm guessing that a lot of the dental EMRs are probably not yet participating in the network. And as it was Zen working a lot with EMR vendors, my lesson on that is, well, I probably should knock on some dental EMR vendors' doors, because clearly some dentists are participating, so there's got to be some value there, right? But to your point, we're clearly missing a huge number. Yeah. The other thing that was interesting is that, at least as far as my LLM could tell, and I didn't have the LLM go in and do another pass on this group, there seemed to be a lot of entries that only had an address or location named, or at least at first view, they appeared to be only address or locations. So that's a data quality thing, for us to kind of dive into. And then dropping down into some of these other groups here. Well, actually, let me go, because I pulled some slides out here for you. Who's at the front of the line? I think they're kind of the folks that we would expect, even though you drop down, your hospitals, health systems, and primary care and independent physician groups and specialty care represent the bulk of all the participants, as we would expect. And I'm sure there's a lot of specialties buried in those groups, right? Where the specialties are represented in a hospital or health system, but they're just not present in the name of the group. And the other thing that I want to call out is, because Carequality has been around for a long time and the rules have kind of evolved, not every individual facility is registered yet in Carequality. So some of the entries that would probably be very visible in TEFCA, because we're much better at TEFCA at registering individual healthcare entities at specific locations. There's a number of participants that are hiding under parents. So when you are comparing Carequality versus TEFCA-based, oh, look, TEFCA's catching up rapidly with Carequality. And I think that is both true and maybe not so true, in that Carequality still may have some very large umbrella organizations that don't necessarily have every single address listed. And if we did have that, there might be a much bigger difference here between these two. But what we are seeing over time is that this TEFCA bar just keeps getting bigger. So clearly there's a lot of momentum in Carequality participation. And yes, I do plan on doing this exercise for TEFCA-based exchange, now that I've kind of learned, how to use the LLM and how to iterate. So what was surprising to me is, I thought it was interesting that dental and oral health popped in the top 25, because I expected them to be lower and be in very low numbers, and they actually were a little bit more represented than I expected. I wasn't expecting physical therapy to be as and make it into the top 25. Again, we have potential data quality issue. And then this was interesting, and Julie will probably find this interesting. So because there's been a lot of discussion around law firms potentially getting data out for under a treatment umbrella use case, which they shouldn't, if law firms are involved at all, they should only be doing that by getting data from patients who have asked for their data. And that would have to be like under TEFCA, that's individual access services. Under Carequality, that would be, patient requests, because law firms can't ask for data directly. There are 11 law firms listed. So those are inactive, however. So the important thing here is that they're all inactive. It's certainly possible at one time they were trying to do the patient access use case, but because we still don't have great adoption of patient access in the Carequality network. That could be that's probably the most likely reason why they may have been here once and then are now inactive. But I thought that was interesting. It is kind of fun to target some specific types of entities and see what you can glean from the names. It is 11:32, so I was just watching my time here. Any other comments or questions on the kind of breakdown of the practice specialty? Emily, I'm going to ask you because I know y'all have been very hard at work on your national network efforts. Does anything surprise you in terms of the participant breakdown?
I mean, I think particularly the the law firms was shocking. But I think, we can relate to the fact that, like, at least from our perspective, it's been challenging for us to find, specific organizations when there's an address that we're looking for that maybe isn't coming up because it is under that umbrella. We haven't really exercised searching other networks, so TEFCA or eHealth Exchange or Commonwealth, because again, those aren't necessarily, we're only participating in Carequality. So, I hope to see improvements with that, just so that obviously we can sort of improve the interoperability efforts across the US. But we have noticed that, in certain instances where, maybe we've got a patient who's been referred by a particular provider, and we search up information about that referring provider to see if there are potentially patient records available, we aren't able to find that address in the network. So, I think that there are limitations with, who is currently partaking or versus who is accessibly searchable. So I think there's a difference between those things, but we have seen improvements. We are currently working on our own, the ability for our system to allow searches and source various facilities, but it's been a learning curve for us as well, obviously, because we're in early stages and we're quite new to interoperability over the last few years. But sessions like this have certainly been helpful. So I'm also still learning.
Excellent. And just looking, Scott, you're interesting because you are a responder. And I'm curious because you're responding to queries from a My Directives perspective, what matters to you when thinking about that big population of folks that potentially could be querying you?
Well, what matters to us is seeing what they do afterwards. And we talk to healthcare providers all the time about the fact that even though they are querying us, and we receive somewhere between 4.5 and 5 million queries, as you all know, to our database of advanced directives and POLS forms every week, which is crazy. It's a crazy number. So we talk to people about the fact that there are queries that people are wanting to find these documents. But it's what do they do afterwards? Are they able to find them in the right place? Are they finding them in some community health tab inside of Epic or Oracle Health or Meditech? Or are they able to do flags and notifications and the things that actually say these documents are here? So those are the kinds of things we look at. Obviously, the fact that there is such a broad range of queries for us, and I guess the sources of those queries is really interesting, because the return on investment for advanced care planning is different depending on the care setting. So right. when you have primary care, or you have the specialty groups or even community palliative, things like that, it's a completely different interest. They're querying us for different reasons than, say, acute and emergency. So it's really interesting data, and for us, it really informs who we're talking to and how we're talking to them.
Yeah. Your use case is so important, and one of the reasons why I like to call on you, Scott, is to make sure people are aware that you guys make the advanced directives available through my directives and advanced care plans. It's such an important problem that you're solving. I would love to hear from some others on the call. If you are a network participant, what's your primary driver for being a participant of the network? I know with our folks from Reliance, Scott and Mike, that you're a regional health information exchange, and it is a value-added service that you can provide to your community providers. And I'm curious, because I know a lot of HIEs talk about this, with a lot of the big health systems already on the network, are you finding that you're kind of filling in some of those gaps for other community caregivers in the community that don't have access to Epic, so that they can also be part of the data sharing ecosystem?
I'm not sure if Scott was going to comment, but I want to say yes. In particular, we're on eHealth Exchange, and I know that some of the smaller mom and pop type shops that are, their EMR maybe doesn't participate. When we tell them that we have access to eHealth Exchange and the VA is on there, and so they can have insight into what treatment their VA, their veteran patients have come in with, sometimes it just kind of blows their mind. They're like, we can actually see that stuff.
Yeah.
And it's a big deal for some of them. I don't know if Scott had anything else to contribute, but to answer your question, yes.
Yeah, thanks for mentioning that, Mike. Just to add to that example, I think the way it displays in our community health record, which is our patient portal for our participants, I think some people who actually already do have access to the VA find our display, our user experience, a little more convenient, because instead of having to look at all the disparate VA facilities, we pull that into kind of just one simple user interface, and it helps them from having to click around. Anything we can do to save clicks, can help their workflow.
Excellent point. And it's funny, and I think Scott touched on this, what happens on the other side. And you all know I'm a huge advocate for getting all the plumbing connected, right? And I feel that, we need to have national plumbing and we need to have regional plumbing, and it's not one or the other. And one of the big advantages that folks like Reliance, folks like Crisp Shared Services provide is that user interface that in many cases is far superior to what the EHRs do with the data. And, I do think that there is, we're starting to move into a data quality discussion of the data being exchanged, but I think that you can't really disassociate the data quality from the data presentation layer. Because you can have super high quality data, but if it's not visualized in a way that's user friendly, it's a problem. And I do have great appreciation for the work that our HIE friends do, and in some cases our health tech vendors do, because we find that is often a problem that our health tech vendors are solving, is they're giving, for where you don't have a regional HIE that can solve that problem for them, they're giving providers a much better way of handling referrals coming inbound, where the visualization is way better. There's deduplication that's been done. Zen is about the plumbing kind of underneath the covers and giving people tools that they need that are helping enable that, those solutions for people. And so our UI that you guys have seen me in today it's not a clinical data viewer. That's not the business that we're in. Our job is to help make sure that that data flows, that the connections are made, and that our customers, whether you're an HIE or whether you're a health tech vendor, have the tools that you need to effectively manage that exchange on the behalf of your customers, on the behalf of your participants. Those are all really great points. Let me just pop in quickly. The one subject that I wanted to touch on that kind of comes back to this whole concept that I started with about trust and who should be engaging in national data exchange from a national network governance perspective is one of the things that we've, if you've been on any of these calls, has been acknowledged is that TEFCA has this more narrow aperture, a more precise definition of who can engage in this required treatment where reciprocity is required, and where you have to be a covered entity. And there are a lot of discussions right now about Carequality aligning, and one of the problems that keeps coming up is, well, if Carequality aligns, who might you be leaving out because of the covered entity requirement under TEFCA? And so part of what I wanted to accomplish in this analysis is start to get a sense of who those kind of entities might be. I think I would expect that some of the folks that fall into the long-term care category might be people that don't engage in, that don't take insurance. Certainly a number of the senior living that specifically designated in our analysis as non-medical would fall in that category. We picked up about 700-800 of them. I suspect that they're underreported in the numbers right now. Social services and community support, correctional health, school, especially, your K through 12. I think some of your university student health centers probably take insurance. Concierge or free clinics, a lot of those got rolled into the individual practice, small group, primary care categories, but we know they're in there. And then others that I plan on still, spelunking around in the data to see what we might be able to uncover. But, these, in terms of conversations about these different kinds of entities that might get negatively impacted if we aligned purely with the TEFCA definition, these are the types of organizations that are currently engaging in exchange, but that might get left out if we fully aligned. And so for those of you who follow those kind of potential changes in national data exchange, particularly in the Carequality network, I think just it's good to be aware that those conversations are happening, no decisions have been made, because these are hard problems to solve. It's true that there are concerns when people fall outside the HIPAA umbrella. It's also true that folks like that are using Carequality, the vast majority of those entities are working with patients that whose care is improved because they have access to that data. And so they are very difficult problems to wrestle with. Learning who's in the network today and being able to kind of assess how we can maybe quickly get to that information was just part of the experiment that I wanted to run, acknowledging that by definition it's imprecise. I am opening it up now for anyone who actually, and of course, my demo kicked me out because we do have two-factor and it does time out. If anybody would like me to do a network lookup, this is our directory. Just to give you guys a quick, kind of give you a quick idea. When I talk about lookup capabilities, we did enable a lot of different ways to do things. So by the name, by the OID, by the address, and then different ways of, do you need the exact OID or just part of the OID to match up? We are capturing purpose of use or exchange purposes. So this is across multiple networks. So you'll see a lot in here. I will also tell you that there are a number of those POUs that are not live or enabled yet, and often aren't even listed on a particular entry. So a lot of the purpose of use information I would consider coming soon and it's not all seated in the underlying directories yet. And then one of the things that we are able to do is display the hierarchical relationships. So we know whether if it's a TEFCA entry, we know what QHIN they're attached to, or if it is, here's a situation where Alameda Hospital is accessing the eHealth Exchange network through Manifest MedX. These kind of hierarchical relationships are very important. Here's one that's they're a next-gen user that's associated with No2 in the Carequality network. So the hierarchies can really help untangle things, as Scott was mentioning. And then the last piece of the puzzle of our particular implementation of the network is the changes. So if I'm a member, so Emily, you guys are a member of Carequality. If you don't have access to this now, you will get access shortly. You will be able to see here just people who have been added over a certain date range. And it takes a minute to load because there's a lot of changes that happen. But it's really useful for kind of monitoring, what new folks are coming into the network that weren't there, last week. So, and if you're having trouble accessing someone, maybe something changed or someone got removed from the directory that you were successfully exchanging with in the past. So those are all the key things that we're focused on for our clients, as well as for anyone who would just like to sign up with us directly if you're interested in RA network participant. All right, I'm opening it up now for just any question that anyone might want to throw out at me.
Marilee, I have one question for you.
Yeah.
You mentioned previously, obviously there was the different directories like TEFCA directory or eHealth Exchange directory that lists the various endpoints or participants. Are those endpoints or participants included in this Zen list as well, or currently are those still siloed based on whether you're participating in eHealth Exchange or whether you're participating in TEFCA?
We are in beta right now, so we've not turned off any networks for our customers that were already customers, since so many of them are cross-network participants. So you have a short window before those go away, Emily, so maybe talk with me after.
Okay.
Yeah.
Okay, great.
We do want to be respectful. We are talking with the folks at the networks themselves and making sure that we're respecting any sensitivities to access to the networks based on participant status. And we may do something simple like if the information is already publicly available, maybe we enable that, but we remove some of the details. So these are all questions that we're looking at and working on behind the scenes, because it's pretty easy for us to just say, oh, if you're a non-network participant, you can at least see in one view the same information that you would see, for example, on TEFCA's website, right? We feel pretty comfortable that that's probably reasonable to include, but maybe we don't include the OID and some of the endpoint information. We just gray those out because we definitely would not want to share that data for non-network participants.
That makes sense. Thanks, Marilee.
Yeah. Mm-hmm. Well, I really appreciate everyone joining this session. I know those of you who show up regularly, you kind of never know what you're going to get from me. I hope that you found this interesting. Some of you who have worked with Claude or some other LLM tools will know that you can definitely get caught up. And Jim came in, for those, that's my husband and business partner. He came in here several nights at like 6:30 at night going, you must stop now. Because, it just is fun to ask these questions. But I was really trying to make sure that the questions that I was asking, at least initially, are going to be helpful. I will tell you that I have other projects in mind. One of the things that I really want to work on is comparing Carequality and TEFCA participants. That's probably one of the most common questions we get asked is, what kind of overlap do we have in those networks? Who might we be missing? Or what percentage of organizations will we be missing if we're not opting into TEFCA? I think it can help people make some decisions. And so that's going to be next week's project, I guess, to see if I can't learn information about that. And then, as always, anything really interesting I learn, of course, I will share with my friends on office hours.
So, Marilee, before you go, just one last question to understand what you've done here. The source data that is driving this dashboard initially or even permanently will be the other exchanges directories, Commonwealth, eHealth Exchange, TEFCA. You're using that data as the source, and then you're going out and filling the gaps where and if possible. Is that how it's working at a high level?
Yeah, and I can't really speak to what I might do in the future, but what I did for this exercise is I used a very dumbed down version of the Carequality participant list with just name and address. And I honestly, at this point, I don't expect to have the need to expand beyond that kind of data for the kind of questions that I'm asking, since so much of it is dependent on what's in the name field. But yeah, I'm just using what's publicly available on the websites, and then use that as my source of data, and then iterated over that data. Most of the work was in the trying to infer specialty information from the name. And because there's such complexity in how those names are put together, that did burn up a lot of time and energy, iterating many
Yeah,
times.
the ones that kill you are practice name Dr. Mark Smith.
Yes, and
Now what do you do?
yeah, well, in that case, we just said it's an individual provider, right? We don't know what specialty it is, but at least we have a clue that it's a provider, that it's like we could tell if it had credentials, then we put that in an independent provider group. I think we put that in a doctor category, as opposed to maybe there might be different kind of providers that are not, MDs or DOs. So there were a lot of interesting questions we had to ask. There's a lot of words like associates and services and healthcare that create complex naming patterns that you have to kind of iterate through. And it's not ever going to be perfect, of course.
Sure.
But again, I think when you look at the relative percentages, it pretty quickly lets you know, and a lot of it's obvious. You would expect a lot of hospital, health system, primary care, internal medicine specialties to be predominant in the network. But then there's this interesting thing that I learned, which is there are dentists on the network, and that's pretty cool, and I think represents an area of expansion.
Thank you.
Yeah.
And so she gets back on Sunday.
Someone made a comment, Scott did, about the concierge medicine specifically. And yes, Scott, I didn't get a chance to ask the LLM about concierge medicine, but I am going to, because I also am interested in that category specifically. Elizabeth, go for it.
Thanks, Marilee. I'm curious if you have any perspective on the mental health exposure, and if that's an area you've dug into. I couldn't see on your little chart. So sorry, I'm on a small screen today.
Yeah, they actually fell into my top. They pretty high.
Interesting.
Mental behavioral health. Yeah, this picked up specifically over 3,000. I think a lot of that is because there are a couple of there's some vendors who have a very strong footprint, like NetSmart. I think No2 has some of those. So there are they kind of, a lot of penetration from one vendor can help increase the numbers of that particular specialty if they have a really heavy footprint there.
Well, and I'm wondering, the other question is, do we have a good understanding of sort of the total universe, and then like kind of the dark matter? Like, what do we see? What's the light that's showing up through these various networks, and what do we think is missing? I'm wondering if anybody's put that together. I know I looked for that a while ago, but since you're on this journey,
Yeah, I think
we-
I'm just starting the journey and I would love to know who else is on the journey with me. So if anyone finds out, so please point them my direction because if I can piggyback on someone else's work, I'd love to do it. Yeah, it's funny because that is one of the questions I was asking myself, Elizabeth, is who's missing? And I really didn't get to spend a lot of brain time on who's missing. My suspicion is a lot of who's missing may be those non-covered entity types where we're still having big debates about are they going to be allowed in to, because right now they're not allowed into TEFCA. I feel like there's the covered entities, there's really strong footprint. But one of the other analysis I'd like to do is like we did the state analysis, but now I want to go back through and say, well, okay, but is there any particular state that's underrepresented based on population? You know, like that's an interesting question. You know, do we have some regions where they have the opportunity to have high participation, but they're just falling below others in terms of their overall participation rate? So that's a question. I haven't decided how to ask that question exactly, but I think that's an interesting one. And that could be because you have a really strong regional health information exchange in that state. And so there that is meeting a lot of those needs. I mean, that could be a possible reason why you might see a lower, you know, participation rate amongst the smaller practices, for example, because the HIE is fulfilling their need already. So that, yeah, there's so many good questions. And please, I encourage everyone, if you think of a question that you would like asked as part of this journey, just email it to me. That would be great. All right. Well, we are a couple of minutes, so we managed to use up all the time. That's awesome. I really appreciate everyone's participation and putting up with me talking always way too much. But hopefully you learned something interesting today, and I look forward to seeing hopefully many of you on an upcoming new Marilee's office hours in the future. Thank you all.
Thanks, Marilee.